Recording in progress.
Good morning, everyone. We're just going through and giving everyone recording privileges. And Liz and Joanna, there's more in the waiting room also.
Thank you.
Thank you. We'll start in just a moment.
And looks good on my end. Liz, how are you doing?
On my end too.
Great.
I still see one person in the waiting room. Can you all see that?
Yeah,
Yep.
I think they're still joining in the waiting room, so we'll let them in as soon as they're there.
Okay, great. Okay, thank you. All right. Well, good morning, everyone. I'm Cassie Sauer. I'm the CEO of the Washington State Hospital Association. Thank you for joining us for our weekly media briefing. This feels like a good news and bad news briefing today. When we were thinking about what we were going to talk about today before the Thanksgiving holiday, it felt more like good news. And then the headlines and news over the weekend makes it feel more like bad news. You all might recall that a couple of weeks ago, we had said we had hoped that this week would be our last media briefing. And I think maybe we need to quit saying that, because last time we said that was when the Delta variant came, and this time we've got a new variant as well. So I suspect we will continue to have these media briefings, but we'll share a lot of information with you all today. And we're definitely on in a pretty serious place of worry today, I would say, is how I would characterize all our emotions. Our panelists are Dr. Seth Cohen, who is the Medical Director of Infection Prevention at the University of Washington Medical Center. Dr. Connie Davis, who is the Regional Vice President and Chief Medical Officer for Skagit Regional Health. Gregor Petty, who is the President of Multicare Deaconess and Valley Hospital in Spokane. And we'll be joined in a few minutes by Dr. Alex Greninger, who is an Assistant Professor at the University of Washington, and also, really importantly today, Assistant Director of the Clinical Virology Laboratory at the University of Washington, which is working to sequence the virus and determine what's happening with the new variant in Washington State. So I'll start with a few opening comments, and then we will turn it to our panelists. I think we've got some really good panelists who are very timely for what's happening right now. So this is the good news portion of the briefing today. So we have a lot fewer hospitalizations. This week, the daily average was about 694 confirmed COVID hospitalizations. And last week it was 806. So that's about a 14% decrease in a week. That is great news. And it's an even bigger decrease when you compare it to a month ago. So again, using that 694 average number from last week, a month ago, we were sitting at about 1,013 daily average. So that's quite a decline, a 31% decrease, an average decrease of 319 hospitalized COVID patients over the last month. So that is great. The ventilator use is declining somewhat, but not as quickly as the overall hospitalization rate. The 7-day average of patients on ventilators is 117. That's a six. Actually, I'm sorry, I misspoke. It's going up. Omicron has scrambled my brain. The 7-day average of patients on a ventilator was 117, and that's an increase of 6% compared to last week's prior average of 110. And that has been a trajectory that we've seen as people get the disease and then they move to being ventilated. And then the worst statistic of all is that we still continue to see deaths. So we are continuing to see 10 to 15 hospitalized COVID deaths on average daily. Hospital acute care capacity remains quite tight. We are continuing to see, and probably each of our panelists could address this, the need to juggle surgeries and care that people need, and so folks are having to wait for care continually across the state. So that is mostly good news. That the decline in the number of hospitalized patients we're really pleased to see. We're also really pleased with the news that everyone is eligible for a booster. We really encourage people to go and get their booster doses. I think that we had previously thought, a lot of folks were more, we've mentioned before that when you looked at the criteria, there were a whole lot of Americans that qualified for booster doses, but now everyone does. And so urge people to go get those scheduled. There is quite a bit of supply of booster doses in Washington state. So hopefully people won't have to wait long to get their booster dose. Also really pleased with the vaccine availability for kids in the 5 to 11-year-old range. I have shared before, I've got a kid in this range. We're going today for a second shot. I am delighted by that. So I think that parents, a lot of parents I know are really celebrating the fact that they feel like they can protect their kids. And, for folks who haven't yet vaccinated their teenagers to really consider that now, we are seeing some concern around the world that kid cases are growing. And so very much encourage parents to get that care for their kids. And I think with that, I will turn it over to Dr. Cohen. Let's see. Yeah, Dr. Cohen, I can't see you right now. There you are. Great. You just disappeared off my screen for a minute. Dr. Cohen, welcome. And really glad to have you to talk about what you're seeing. And I know you're going to address, which I said before we started, Omicron is now my least favorite new word that I've heard in a long time. So Dr. Cohen, please tell us what you're thinking and what you're hearing.
Thank you so much, Cassie. Hi, everyone. I'm Seth Cohen, Medical Director for Infection Prevention at UW Medical Center. Thank you for having me. So I'll just talk a little bit about the unsettling news about the latest variant of B11529, which has been named Omicron, a variant of concern by the WHO. And I just say first, most importantly, I'd like to acknowledge that there is still a lot that we do not know about this variant of concern, and we will be learning much more about it in the coming days and weeks. And second, I think about Omicron and all variants as really a symptom of a true emergency, and that is lack of access to vaccines globally. And until we decrease the proportion of unvaccinated people in the US and around the globe, we will continue to hear about new variants with some frequency every few months. And lastly, on that point, I'd really like to express gratitude to the researchers in South Africa and Botswana for identifying this variant and for working so quickly to share this data with the public. We could not have done this without them. So when I think about new variants, there are 4 main questions that we typically ask. And so the first one is, how transmissible is this compared to Delta? And the answer is we don't know. There are very preliminary signs that this could be a concern, but right now the number of cases is extremely low, and I would say very, very difficult to interpret with any certainty. So on the question of transmission, we don't know. The second question is whether disease severity is any different with this variant compared to Delta. And again, we don't have any information to suggest that symptoms due to Omicron are any different from any of the other variants. And please remember that all variants are capable of causing severe disease. And that is really why, just as Cassie was stressing, prevention of infection, primarily through vaccination, is so, so important, regardless of what variant you're dealing with. The third question that I ask is, how effective are current vaccines or natural immunity from other variants against Omicron? So if you're vaccinated, how likely is it that you could get infected? Or if you have recovered from infection from a prior variant, how likely is it that you could become reinfected? And we don't know yet whether there has been a change in efficacy of the vaccines. This new variant has approximately 30 mutations, about half of which are in the receptor binding domain. And so based on this profile, there are some scientists who are concerned about partial immune escape. And I would just say we do not have any in vitro or epidemiologic studies to support this yet. And I'll point out that we have not yet seen a variant that can completely escape immunity due to vaccines. And so vaccines still remain a really vital backbone in our fight against COVID-19. And lastly, on that point, we've seen prior variants that were associated with decreased vaccine efficacy, but they were completely unable to take off globally because they were just elbowed out of the way by Delta. So vaccine escape, while concerning and absolutely needs more study, is not really the only issue with, or the only factor that plays into a variant taking off around the world. And then the last important question that I think is really key to address is how are diagnostics impacted? And Dr. Greninger can talk a little bit more about this. We know that the PCR tests, which are widely used to diagnose infection, should continue to work with this new variant. We do not think that rapid tests will be impacted, and there are currently studies underway to evaluate this. So I'll just close with what I do know, and then happy to open it up to questions. What I do know is this is not a new virus. This is only another variation of one that we've seen, that we've been dealing with since the winter of 2019. I would encourage people to take appropriate precautions while we're in this information gathering stage. And we expect that current mitigation strategies, including distancing, masking, improved ventilation, and hand hygiene, should continue to be effective. I would not be at all surprised about Omicron cases being reported here in the US, in the next few days or in the very near future. And as we continue to hear about these variants every few months, we will continue to hear about them until we are better able to achieve vaccine equity globally. So I will close there and happy to take questions now or at the end, Cassie, whichever you prefer.
Let's go on through all of our panelists. I will ask you one question though, about masking. And I know we work very closely with Dr. Duchin at Seattle King County Public Health. And one of the things he's really been emphasizing of late is wear a better mask. And he has said we don't have any need for people to continue wearing cloth masks, that people really should be moving to something that's more protective. And could you share your thoughts on that, the kinds of masks people should be wearing, especially with the concern about this new threat?
Absolutely. And even, Omicron aside, I think as the weather is changing and people are moving indoors, I think having a well-fitting, high-quality mask is absolutely key. Thankfully, there are a lot of options on the market now that we did not have, a year and a half ago. So, for instance, KN95s are very comfortable. You can wear them for extended periods of time. And I would say, there's a wide variety of cloth masks. Some of them have filters in them that people may find comfortable, and those are probably effective as long as they really fit your face, do not have any gaps, and you can inhale and exhale through that filter. But as long as it's multiple layers of fabric, a well-fitted mask, and high quality, that is really, that should be the baseline for our community.
Thank you. And I do want to emphasize that those masks are widely available. One of my responses to the Omicron news was to restock my masks, and it was quite easy to find KN95s. So I really encourage people to do that, especially if they're going into high density places like some sort of event or airport or train station or any place that they will be around a lot of strangers. All right, Dr. Davis, would love to hear from you. And I know particularly one of the things that we're concerned about is hospital capacity. We've, as we mentioned, people are continuing to have to wait for care. And one of the things that you all have been experiencing in Skagit is some long stays of patients that have been hard to move. So I'd love to hear about that as well.
Well, thank you, Cassie, and thank you, Dr. Cohen, for your very thoughtful presentation. First, just setting the stage, right now we have a Skagit Valley Hospital. It's a 137-bed hospital. Current capacity today is around 110 admitted patients, and of those people, 20 of them are COVID and 5 are on vents. So for a relatively smaller to medium-sized hospital, we've had a significant number of COVID patients, and we've been pretty consistent over the last several months. At Cascade Valley Hospital, we've consistently had in a 25-bed capacity normal day, about 5 to 6 individuals, and today the same with a 1 to 2 on a vent. So it continues to move forward with the same message. And then as far as capacity, we are having limitations because of the difficult to discharge individuals. Again, of a 137-bed facility, we have 26 patients in Skagit Valley Hospital who we cannot discharge to an external location. And these folks fit into 4 different categories. There are those individuals who have dementia and require special care, those who have developmental delays and also require special care, those who need respite care or longer term care, for instance, IV antibiotics, that we really don't need them in the hospital to administer that type of care. And then there's the pediatric behavioral health issues. In the dementia front, as we know, we have a markedly increasing age in our communities, and people are not planning for their residential needs or their care needs as they age. We're having difficulties with placement in SNFs, and geropsych is under-resourced, and we need increased funding. Part of what we're finding is that the funding, although it has been increased, and thank you very much to the Washington State Hospital Association work, it isn't adequate in order to meet the need. Likewise, the workforce requirements and skill sets needed don't meet the needs of what the community is presenting themselves with. And then another part of this equation has to do with primary care, making sure that they are making their patients aware of the need early on to make sure they have durable powers of attorney, that they have their care desires and quality of life documents done, when they can really think about these things and not wait until the very end. As far as developmental delay, we know that there are very limited resources, residential resources for this, and we've had multiple individuals who have stayed with us for over 100 days and one individual for almost an entire year. We have, as far as the respite care, we haven't had the ability to discharge individuals to locations, especially if they have special needs such as dialysis or if they have behavioral problems or substance use on top of their long-term antibiotic needs. And then on pediatric behavioral health, we've had a couple of 12-year-olds recently who stayed with us for over a month. Many of these have to do with suicidal ideation. COVID hasn't helped the mental status of these pediatric patients. And in our community right now, we have limited services. All of the services in the community, including Catholic and Community Services, Compass Health, and for instance, Seymour, none of them are taking new patients. So the bottom line is the emergency room is really the only location that is available for distressed families or others to drop people off. And we've also heard quite a few stories where the advice from external organizations or care providers is to go ahead and drop them off in the hospital. And so I would ask people to really look seriously at this, to realize if this is the behavior that is necessary for getting people to this type of care, the acute care resources are going to be stressed, and we are then thus boarding more and more individuals in our emergency rooms and turning actually some of the emergency room into an intensive care. And with that, I will turn it over to Cassie.
Thank you, Dr. Davis. And this has been a point we've reiterated multiple times throughout this pandemic and wanted to emphasize today with the potential emergence of the emergence of a new variant. As Dr. Cohen said, we don't know what's going to happen with it, but it's certainly something that's concerning us. We have to have space in our hospitals to care for people. We don't have enough space right now. People's care is being delayed, and hospitals should not be used as housing essentially for people who don't need hospital care, but don't have another place to go. That is not a good solution. And it's a solution that threatens people's health from a variety of, from COVID, from heart attacks, car wrecks, people who need acute care, hospital care need to be able to get it and not have the space all taken, or much of the space taken by folks who don't need it. Greg, we'd love to hear from you and what you're seeing in the east side of the state.
Greetings from Eastern Washington. Thank you for having me. As mentioned, I am the president of both Deaconess Hospital and Valley Hospital here in Spokane County. Deaconess is the more tertiary of the hospitals. Valley is a community hospital. It's interesting to hear the conversations from Dr. Cohen and Dr. Davis, and I appreciate their points. I can only reiterate Dr. Davis's concerns about hard to place patients. This morning, about a third of the patients at Deaconess could be moved to SNF, adult family home, or other non-acute settings if they were available. We've even contracted with some of those and at reserved beds and are paying additional for those beds to move people out. The problem is it's working in 2 of the 3 places. The third place can't recruit staff. And so we're challenged is the same staffing challenges in the hospital are also impacting our post-acute brethren. And it's been an interesting challenge across the board. So at Deaconess, that's almost 65 patients of a 180 patient census. At Valley, it's a little bit less. We're about 20% of the population is waiting for placement. So that continues to be a challenge. On the good news front, as Cassie mentioned in the beginning, our numbers are down. Eastern Washington, including Kootenai County in Idaho, our total hospitalizations were at 131 this morning, which is down about 20 over the weekend, which is down from a high in October of 350. So it's really dropped down. The problem is, was already mentioned, the ICU hospitalizations have continued to be high. And so those patients that are admitted are, unfortunately, we're seeing a higher percentage of those COVID patients taking up ICU beds. Again, that challenges us from our ability to do things like open heart surgery. At Deaconess, you need ICU availability. All of these numbers have made, we have not gotten back to normal yet from the Delta variant as far as outpatient and particularly inpatient surgical procedures. Those patients who need a bed overnight, we are still titrating those patients and those procedures based upon our ability to staff and our ability to cover those beds because of the number of COVID patients that we have in our hospitals. And I think that's pretty consistent across the state. Even Shriners for Hospital for Children is doing the same thing with their inpatient surgical patients because of the number of their employees that are out. So it's a real challenge for us as we look at this day to day. It is a day-to-day thing. As I said, I'm happy we're much better than we were. I'm as worried as Cassie is. Dr. Cohen made me feel a little bit better and make sure that I get my booster shot this week as scheduled, but I encourage people to do that. We continue to promote boosters. We continue to promote just vaccine in general in our community, masking and all those good public health things to help stop the spread of whatever variant comes along. But I will say that based on my rounding this weekend, I had the opportunity to come in and round at both hospitals. Our staff's morale is probably better than it's been in a long time because the numbers are down. But I think to some extent, the news that we're seeing today is going to chill them a little bit about what could lie ahead, because the experience of Delta was very traumatic. I think we all felt like we were starting to get out of the woods, and people really have taken it hard over September, October, as those numbers really ramped up. But that's where we are today in Eastern Washington. I think I looked at my colleagues from Sacred Heart and Providence Holy Family, and their numbers are directionally the same as ours are. I think the good news for Northern Idaho is Kootenai Hospital is down to 62, which seems like it's still really high, but when you consider that they were on 120 at one point, that and Kootenai does impact what happens in Spokane County as patients do come across the border. There's not a gate at the border, and we saw a lot of patients from the Idaho. We're not seeing them right now. It's back to kind of a normal percentage because Kootenai's opened up. So that's my report, Cassie.
Thank you so much, Greg. And I'm glad to hear the good news about the declining cases in both Washington and Idaho. So Dr. Greninger is going to join us, I think around 10:35. So we have about 10 minutes till he joins. I'd like to pause here and take any questions and answers for me or the panelists, and then we'll turn it over to him. I'm sure there's a lot of interest in hearing what he has to say, thinking about the sequencing of the new variant. So you can feel free to ask your questions orally or put them in the chat. And I'll start with the first question in the chat. With the increasing recommendations for booster shots paired with the lack of information on the efficacy against Omicron, can those who received a full vaccination without a booster still consider themselves fully vaccinated? What's the length of efficacy for booster shots? Dr. Cohen, you want to take that?
Yeah, it's a very good question. And we don't know the length of efficacy for booster shots. What we do know about boosters is that not only do they boost waning immunity, but they really surpass, antibody levels in your immune response that you received from the prior series. So boosters are way better than just having 2 doses. There's still a lot to learn about Omicron and what being fully vaccinated means. My personal suspicion is that there will be some spillover between your own immunity that you have from vaccines and what we will see with Omicron. So I think that is good news, and that's just based on prior variants, but there's still a lot that we need to learn about Omicron before we decide on definitions of what is fully vaccinated or not.
And I want to follow up on a question that we've gotten before. What do you think about mixing and matching shots? Do you have any recommendation about that, or should people just kind of get whatever booster they can get?
I think I never miss an opportunity to get someone vaccinated. And so if something is available, they should absolutely go for it and not overthink it. I think the benefit of some of the mixing and matching is that if somebody may have had an adverse reaction to a prior dose, they can try something else. And it's nice to have so many options available.
Thank you. And I think we do have Dr. Greninger on now. Is that correct? If you could turn
I am here. Yeah,
Great.
sorry about that. Oh, I'm listed
Great.
as Susan Gregg. That's funny, but I
Excellent.
clicked on the link she sent.
Well, welcome. We really appreciate. I think you just might have just muted yourself again. So we did some opening comments and would love to hear from you what you're working on and thinking. Dr. Cohen did a great overview of his thoughts about Omicron, which was a lot of, we're not sure yet, but keep wearing your masks and get your boosters. If I could summarize it in one sentence, but love to hear your thoughts as well.
Well, I definitely agree with everything Dr. Cohen said here. I think, I usually come out here to talk about testing and what's going on in the state of Washington in that area. I think the first thing anytime a new variant comes is people want to know whether the existing tests are going to miss it or there's going to be any problems. Right now, obviously we haven't detected Omicron, so it hasn't been formally tested. But if you look, we can look, in silico in the computer and look at how well our tests are going to perform. And there's really no evidence that we're not going to be able to detect this variant. I think we've seen it with all the other variants. There really has been very little effect on the testing performance. And a key point here is that almost all the molecular tests that are performed have at least 2 targets. And so even if there were some sort of mutation or one of these variants that affected one of the targets, the other target would pick it up. So every test has sort of an insurance policy with it. And then almost all of the antigen tests target the nucleocapsid protein, which is not highly mutated. Most of the mutations in Omicron are found in the spike protein, as Dr. Cohen noted. And so from a testing standpoint, we're going to be able to detect this. This variant also Omicron has the same sort of hallmark that Alpha variant did, which is a small deletion in the spike protein, which the thermo-TACPath kit one of its targets will fail at detecting, but it has 3 targets in the test. And so it's actually really great for being able to rapidly screen for candidate Omicron variants, because there really are almost no other strains or deltas that have this deletion. So now it's highly specific for Omicron. And so you've seen that. That's probably how the Netherlands was able to get their data so quickly. That's how South Africa and the UK are sort of doing their own surveillance. And, we have that test. It's not our favorite to run from a workflow standpoint, but what we do in these scenarios and what we're doing right now, and I did it yesterday, is basically start running all positives that we detect through this test as sort of an auxiliary screen to try to pick up Omicrons and get a quick look. We're also sequencing somewhere around the 800 to 1,000 sequences a week. Washington State is one of the best covered states. For a while there, we were the best. I think now we're like, in the last 30 days, we're like sort of like top 5, top 10 in the United States when it comes to sequencing. There are a lot of really smart and great groups here that can perform that. And so we have sort of the best eyes out there when it comes to looking for these variants and reporting on them. So I think, as soon as Omicron is here, we'll be one of the first to pick it up. That said, a lot of that will depend on sort of flight paths out of Europe and South Africa. But from a testing angle, tests can detect it. We have the ability to get sort of rapid screening for Omicron, and we have a great sequencing capacity here in Washington State. So we're well set up in that regard. But I want to completely agree with Dr. Cohen that, boosters, there hopefully will be some level of cross protection. And what you see with these mutations is it's a cut in the neutralizing titer for protection. So the best way to fight that in the short run is to drive your titers as high as possible. So even if you're dividing it by 8 or 10 fold, you're still within a level of protection. And so boosters are really what's up.
Thank you. Can you talk about, you said you were in yesterday looking at some of these. So did you all have run positives against the testing for Omicron already and have not found any? Is that correct?
Yeah. Well, so the first big picture is we're sequencing, like I said, of almost 1,000 viruses a week. The delay on that is maybe about a week and a half.
Okay.
And so, we have all that. Those are whole genome sequence. So we can very clearly see that we have not detected Omicron in our whole genome sequencing data. And then, like I said, just yesterday and starting today, we'll do our positives on this TAC path assay to look for that hallmark. And we have not seen any so far by that testing method. But I would much prefer to lean on the sequencing data because it's whole genome. It's across. You get all the data, and there we have not seen it.
Great. And so, what would you all expect, just based on it? You mentioned the travel patterns out of Africa and Europe, that probably the East Coast would see this first, most likely. I mean, I know it's a guess, but that just where do you land when you come from Europe? You often,
usually it's New York,
JFK.
Right? I
Yeah.
mean, the direct flights are Newark and Atlanta. I thought,
JFK, yeah.
And to South Africa and then via Europe. But I mean, Duncan McConnell had a great tweet yesterday. He's a chief scientific officer for the CDC in charge of these sequencing efforts. And the first alpha was found in a rural Colorado county. I feel like I forget whether it was beta or beta was found in somewhere in South Carolina. Delta was found, I think, first in sort of Palo Alto. Stanford found, I think, the first one, if I remember correctly, in the U.S. I think we were found like second or third. So there's a part of it that it can be quite random, and so we all have to be up on it, and that's why we've done our best we can here in Washington State to take care of our neck of the woods.
Yep. Thank you. We really like your quote, boosters or what's up. I think that's
and Max, I don't want to be totally just a booster only for boosters, but I think that it's the whole multi-layered approach, as Dr. Cohen said. I mean, masks work. What we're doing right now, like we're talking to each other and we're not giving each other viruses. So Zoom also works, being socially distant. But I mean, look, we know that there's still. I mean, the other thing too is there's still a lot of Delta out there, right? There's a lot of COVID. It's not Omicron. That's the thing that happens with these variants is people get very focused on the next thing, front running. We know when people, this around this time last year when Alpha came out, and Alpha didn't really peak here until like March, right? It takes time. Even exponential growth takes time if it comes. And it is a dominant variant. If it's a fit variant. And so during that time right now, you still got to take care of sort of the blocking and tackling for all the COVID, right? As well as flu, right? I mean, there's a lot of flu in the rest of the United States. Great time to still get a flu shot and cover yourself over the winter.
Thank you. Dr. Cohen, Dr. Davis, Dr. Greninger, would you all advise people to reconsider their holiday travel plans in light of the Omicron variant?
I'll give Dr. Davis a chance to speak if she'd like to.
I think that people need to use the tools that they have. And I think they need to be reasonable about what they are going to benefit from the travel versus what their risks are and who they are. So I think looking personally at what your risk factors are and making sure that if you've got all the physical barriers and you've got your shots and a booster, you could still entertain the travel.
I think that makes sense. And as Alex mentioned, we are still dealing with a lot of Delta here. And so any travel plans need to take Delta into account. I don't think it's a great idea to travel to, hotspots with known Omicron until we have more information. But I think we've also seen that, travel bans in general have their own challenges and can be quite stigmatizing, and that Omicron is likely in many, many parts of the globe, even if we haven't yet detected it.
Including here. I think we had a little chat before we started, and I think all of our panelists and I agreed wholeheartedly that Omicron is in the US. I think there's almost no chance that it's not. Anybody else want to comment on that? Travel plans? It's tricky for sure.
Certainly, I think it's a personal decision in terms of your own risk factors. And, I think it's helpful to get a little bit more information on Omicron. I think right now, everyone's sort of in the 2 week is the common answer, right? I mean, even just So even if you wanted to characterize this, I mean, I think there are probably every scientist around the world has probably put the same gene synthesis order in the last 24 to 48 hours, which is this particular spike protein. And some places maybe can get it to you in 11 days and some in 13. And then also, hopefully, the individuals in South Africa can culture the virus and maybe get it even faster. And then we can get an idea of, in that time, of the chance of reinfection among individuals who have been infected with Delta or well vaccinated or boosted. All of those populations matter. And then we get some information from the virus in a dish about what the cut in that immunity is. But ultimately, this has to play out outside of a dish. It plays out in people. And so, you know, that's the dominant thing. That's the thing I follow the closest, is what are the case numbers coming out of South Africa right now, honestly.
Thank you. And I think we also really want to echo what Dr. Cohen said about gratitude for the scientists of South Africa who were so generous in sharing this information quickly. And we've said this multiple times on this media briefing, but really would like to see vaccines more available all over the globe. We are all, to be good world citizens and to be sure that people all across the globe have the same chance of protection against this deadly disease, but B, we are all at risk when the virus has a chance to multiply in other parts of the world. Okay, here's another question, totally different. How long is it going to take hospitals to catch up on elected procedures? Greg, could you give us a sense of what you think? And this is kind of a wild card about, well, are we going to see more COVID?
Yeah, you know, I saw the Ariel, thanks for the question. I saw it in the chat. I've been thinking about the answer. You know, if we stay the course and we don't get a monster spike again, I think it's going to be well into the first quarter of 2021 before we catch up on procedures. We've seen, you know, we're doing a lot of outpatient work. Our doctors are taking advantage of that because our limiting factor right now are available inpatient beds. It's really not OR people. And so I think, you know, my two hospitals, I can only speak to them, we're at about 80%, but heavily weighted toward the outpatient side. I think if we can get, yes, I do mean first quarter 22, not 21. I said 21, somebody just corrected me. I appreciate that. But, you know, we're working, we're running Saturdays to catch up on outpatient stuff. But I think the inpatient, you know, the hip replacements and the knee replacements that are elective, the you know, other surgical inpatient procedures that are elective, I think it's going to be well into the new year before we've caught up, if we don't see another big spike. And you know, we could have a spike coming out of Thanksgiving that throws it, without Omicron, that throws us back a little bit. So that's kind of my sense from talking to my colleagues across town. We're all in that same boat. We're trying to be collegial so we understand what each other are doing, but that's kind of where we are.
Thank you.
That's a best guess.
Dr. Davis, any comment from you about when you think you'll get caught up on your backlog of procedures?
I think it will be a couple of months, again, predicated on the behavior of the virus and other clinical events. Really, quite frankly, it's staffing. And even for us, some of the OR staffing has been a bit difficult. I give a lot of credit to our surgeons for coming up with new paradigms for outpatient procedures. They've been really very, very clever, and the nurses that are helping support that, and physical therapy. So there's been a whole new paradigm of how this care is being delivered that's been developed.
And I think releasing people to home faster than in the past, and really relying on family support to help people. But that, you know, it's always important to emphasize what we mean by elective procedures, which is not, people hear that word and they think facelifts. And elective procedures for the kinds of things that are being canceled are heart valve replacements, removal of slow-growing cancerous tumors, colostomy reversals, you know, things that are very serious for the patients who need them. We have a staff member at the Hospital Association whose father needed a cardiac procedure that was really quite significant and had to travel a long distance to get it. He left the Puget Sound area to go down to Vancouver, where they were able to accommodate him. And that's, I think that's happening quite a bit too, is people having to go someplace else when their hospitals are full. Okay, let's talk about Thanksgiving. The question is it too early to tell how the Thanksgiving holiday might have affected COVID infection numbers? yes, I think it's too early to tell. And then so when do we think we'll see a surge of cases? And if so, when would we be able to spot that? Dr. Greninger, you want to take that?
Yeah, sure. I mean, so most of the things that happen around Thanksgiving are sort of substitutions of when there's actual testing. You know, like there's the fewer sites are open on Thursday or Friday. We had back higher volumes on Saturday. We had actually really high volumes on Tuesday for travel associated potentially, and Wednesday. So you know, I expect for cases, if they show up after Thanksgiving, you'd expect a 3 to 5 day incubation period. Followed by a few days before someone sort of feels symptoms and really presents, sort of 3 to 5 days. So we're looking about a week after the holiday before you might start seeing some cases. You know, what's interesting is last year, most of the increase was during the month of November prior to Thanksgiving. The spike that happened after Thanksgiving, between Thanksgiving and Christmas, sort of actually paled in comparison to what happened from late October and November. And certainly the kinetics are even more weird this time based on the Delta sort of surge that happened in August, September, and into October. So I do think there'll be a little spike after Thanksgiving, but compared to what's happened before, it might actually be a little bit minor. Honestly, don't know what to expect.
And then another question for you, Dr. Greninger, is just to clarify: are UW virology teams changing your surveillance and testing models to search for Omicron, or are these processes ones that have already been used in place to test for Delta and other variants?
I would say so. Technically, we are changing. It's a very subtle change. It's only because it has this Delta 6970 amino acid deletion in the spike protein, which is specifically targeted by one of the tests that you can then use as and it's very highly produced. It's one of the cheaper tests, honestly, too. So after we'll do normal clinical testing for samples, nothing will change there, all the same pathways. But we will take our positives and run them on this test, the ThermoTac path, to be able to rapidly screen, because that means within, very seldom do you get an opportunity, a specific mutation that you can use to screen that's part of EUA test that you can get data on in a few hours. So we'll batch those. So it won't be a few hours, but it'll be like the same day or next day. We can have an understanding of all of our positives if there were any Omicrons there. And then we'll still reflux those to sequencing. So in that way, we won't actually change. We'll keep up the surveillance that we're doing. We'll just add sort of an intermediate step that will allow us to get, especially right now as we're trying to get those rapid turnaround times. The clinical testing won't change. The sequencing won't change. We're just going to add a little step in the middle that will allow us to get faster results back from the Omicron standpoint.
Thank you. Another question: hearing some reports of long wait times, maybe a week or so to get a booster appointment, and that Omicron will move people who have been, I think both two things. Omicron will push more to get boosted, but also the recent announcement by the CDC that you could get your booster if you didn't qualify into one of the high-risk categories. Both those, I think, would be pushing the supply. Do we believe the state has enough supply? I don't know that we know this. I think the state's probably a better answerer, but maybe if any of you are running vaccine clinics, maybe you could talk about, if you know, how long the waits are, what the demand is like.
I can say I was looking for a booster for a family member, and I agree. A lot of the, CVS, Walgreens, Bartell's, Rite Aid, if you're going to get a booster, it takes, you're not going to get an appointment until, sort of into the maybe second week of December. Sometimes some of them pushing out to January. And a lot of that is prioritizing first doses. And then, of course, I'm sure it's staffing. So if you need a first dose of vaccine, then you can get in really same day, next day. But I imagine most of that's staffing, but I probably shouldn't be the one to answer this one. Anyone else who's running an actual vaccine clinic.
I think that's right, Alex. It's, it's also the pediatric doses, which come from a different, allocation. And those have been, the allocations have, there has been some uncertainty with those. And so it's sometimes hard to plan in terms of a pediatric wait list. But for adult appointments, I think your assessment is right.
I do think there are a number of places that are offering walk-ins as well. So I think I've definitely heard that appointments may be hard to come by, but there are walk-in clinics. I think we are at the end of our questions. Anyone else have a question they want to ask orally or put in the chat? Well, I think just a booster, I can't remember what you said. Boosters is where it's at or something like that. Boosters is
Boosters are what's up.
Boosters are what's up. Thank you. I think that's a really good message to leave with. Continuing to wear your mask and keep your distance. This is not a time to let down a guard. I think we're really pleased to see the COVID hospitalization numbers decline, and sure hope that continues. So there's this is definitely a time of, we feel like we're in a bit of time of flux. So we just put a question in saying, today the president said Omicron is a cause for concern, but not to panic. Does that sound right to you guys? I didn't sleep as well this weekend as I've been sleeping. I don't know what how other folks are handling Omicron news.
Go ahead, Greg. I saw you come off mute.
Well, I'm not the clinician of the bunch. I'm the administrator of the bunch, but I think that we handle Delta. We'll handle the next one that comes along. I don't think it does anybody any good to panic. I think it does everybody good to think. And think means vaccine boosters, masking, social distancing, washing your hands. Those things work. And no matter what variant it is. And I think that's what we need to do is keep people from panicking, but really work hard on vaccine and vaccine booster side. I mean, let's face it, Eastern Washington lagged Western Washington and continues to lag Western Washington in vaccination. And so I'm focusing my speech on vaccination and not panic.
I think that's very well put, Greg. And Dr. Davis earlier said that this was, we knew this was going to come and more will come. This is a disease that goes in waves, and I think after the summer when what seemed like all the maybe it's over, and then it wasn't over. I think we've all gotten more realistic maybe about what's headed our way, and know that we may see more waves. And so those as much planning as we can do and as much caution as we can take to keep ourselves and our families safe, I think is really key.
And if I could just add in from a booster's perspective, I just checked our website and we have boosters available at Smoky Point starting December 10th. And then we've got some at Stanwood on the 13th. So we still, in the middle of December, we've got booster doses available.
Great, thank you. All right, well, I think we're at the end of our questions. Thank you so much to our panelists for joining us. Thank you to members of the media. We really appreciate you helping to get the word out. I think that leaving everyone with this message of don't panic, but think and plan and be cautious and get vaccinated is the best thing for people to do. And Dr. Cohen mentioned that that clinics are prioritizing first and second doses, and that for sure, if you have no vaccine, I mean, if you're vaccinated, get a booster. If you have no vaccine, really get a vaccine. If that is key. I mean, if you are unvaccinated now, you are at such risk. So we really, really urge those folks who have not gotten any vaccine doses to reconsider for their own health. We are still seeing, 10 to 15 people a day in the state die of COVID, and they are almost all preventable. And it is a tragedy. So we really, really would like that to stop. So encourage that to happen. Any last comments, panelists? All right, thank you. Thanks so much for joining us. Bye.